Hi, I'm Dr. Jeffrey Friedman. I'm the medical director of the Bariatric Surgery Center at the University of Florida in Gainesville, Florida. I'm here today to introduce our team and to talk to you about obesity and some surgical options for the treatment of obesity. So first, let me introduce our team. I'm Jeff Friedman. I am originally from Mississippi. I did medical school at the University of Mississippi, and I did my residency training up in New York through Columbia University. I'm fellowship trained in minimally invasive and bariatric surgery, and I've been in the state of Florida in either private practice or at the University of Florida since I finished my residency. I'm a member of the American College of Surgeons and also a fellow of the American Society of Metabolic and Bariatric Surgeons. I have a lot of experience both with gastric bypasses and sleeve gastrectomies, as well as revisional surgeries. Dr. Isengard joined us approximately 3 years ago following his fellowship in Los Angeles in metabolic and bariatric surgery and minimally invasive surgery. He's originally from Russia and moved to Michigan when he was 14. He's been with us now for 4 years and does a lot of our foregut surgery as well as bariatric surgery. He has a wide range of experience, including gastric bypasses, sleeve gastrectomy, and revisional surgeries. He's also a fellow of the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery. Our newest partner, Dr. Crystal Johnson-Mann, has been with us for over a year now. She finished her fellowship at the University of Virginia in minimally invasive and bariatric surgery and has been with us since that time. She's also a fellow of the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery, and also has a wide range of interest in bariatric surgery, including gastric bypasses, sleeve gastrectomy, and revisional surgeries. So since you've met our team, let's talk about the disease of obesity and what we're going to learn today. We're going to learn about obesity and how it affects your daily life, what it's costing you, what the surgical options are, and finally what the next steps will be if you decide you're interested in pursuing surgery with us. So obesity is a disease, and it's a disease that we tend to oversimplify, but it's a lifelong, progressive, life-threatening, costly, genetically related disease that's multifactorial and related to excess fat storage. For morbid obesity, we define it when your body mass index gets to be above 40. Your body mass index is calculated by your weight in kilograms divided by your height in meters squared. To easily find your body mass index, you can Google a body mass index calculator and put your height in inches and feet and weight in pounds and calculate it out. We know that people who are morbidly obese develop certain diseases because of the morbid obesity that affects every organ system in the body from head to toe. We know that it affects the heart, the lungs, it affects your endocrine system, it affects your musculoskeletal system, it affects you from head to toe. It increases your risk of developing certain cancers even. And once you become a certain weight, once your body mass index gets to a certain point, these risks of comorbidities associated with obesity go up as well. And we see a trend worldwide where people are gaining weight and obesity is becoming an epidemic. And because of this, we're seeing the incidence of the comorbidities such as diabetes and high blood pressure, high cholesterol, heart disease, sleep apnea, arthritis, fatty liver disease, heartburn, depression, urinary stress incontinence, and menstrual irregularities, to name a few, skyrocket as well. Endocrinologists are worried that in the upcoming years, there aren't going to be enough endocrinologists to treat the patients who develop diabetes. The Center for Disease Control is predicting that approximately 50% of our population is going to be diabetic within the next 20 years. And this is mirroring and related to the rocketing and exponential rise in rates of obesity. As I mentioned, obesity and the disease of obesity, which is an inflammatory disease, affects every system in your body from head to toe. It's an epidemic and it's affecting billions of people worldwide. Approximately 2.3 billion adults in 2015 were estimated to be overweight, and more than 700 million adults were estimated to be obese worldwide. In the United States, we've seen the rates of obesity go up exponentially in the last 30 years. The Center for Disease Control started tracking these numbers in the mid-'80s and have followed them since by state. We now know that there is not a single state in the country who has an obesity rate in their adult population under 20%. And in fact, over half the states have an obesity rate in their adult population over 30%. This equals approximately 72 million adults in the United States. And just as concerning is that approximately 1 in 5 children under the age of 19 are now considered obese. And what we're seeing is that our children are growing up and becoming bigger than we are. And for the first time in American history, it is believed that the average life expectancy of an American is going to go down instead of up. What causes obesity? In a very simple way, it is measured by energy in versus energy out. Calories are a measure of energy, and the more calories you burn, the more weight you will lose. Now, we all know that it becomes more complicated than that over time, and certainly I have patients who regularly tell me that they barely eat any food and barely ingest any calories and have a tough time losing the weight. Well, this is where obesity as a disease becomes a lot more complicated, and it is related to genetics, it is related to your environment, it is related to metabolic and endocrine diseases such as diabetes and hypothyroidism, and we know that obesity is lifelong and progressive. We know that obesity is a genetically related disease because we can take 2 genetically identical mice, modify one specific gene in one of these mice, and one becomes obese, while the other stays at a normal weight. The environment has influenced the disease of obesity just by portion size alone. We also live much more sedentary lifestyles, as you can see. But you're not alone. More than 65% of adults are overweight or obese, and approximately a third of children are now overweight. In the United States, about 5% of adults are considered morbidly obese, and in 2003, this added to about $75 billion in healthcare-related expenses and 325,000 deaths related to obesity annually. I mentioned before that the Center for Disease Control started tracking statistics of the rates of obesity in the adult population per state in the mid-'80s. And this came straight from the Center for Disease Control's website. But they broke it down by rates in the map. And as you can see, the rates of obesity in these states in the United States have skyrocketed over time. In '97, we saw a few states, including my home state of Mississippi, which reached an obesity rate in the adult population greater than 20%. In 2009, we see a segment of the United States, specifically in the south central U.S., with an incidence of over 30% of obesity in the adult population. Fast forward to 2011, and I want to focus on Colorado. Colorado is the last remaining state with an obesity rate of less than 20%. In 2011. However, by 2017, every state in the United States has an obesity rate over 20%, and we're seeing several states with an obesity rate over 35%. This has become an epidemic. This is costing our country billions of dollars in healthcare-related expenses, and it is costing people years of their life. So now in 2019, it is estimated that the annual medical cost associated with obesity and the comorbidities related to obesity is as high as $150 billion. If you're obese compared to a person of normal weight, you are likely to spend close to $1,500 more in healthcare-related expenses out of your own pocket than someone of normal weight. Now, as you can see, as your weight goes up, by body mass index, so do your healthcare costs. And unfortunately, this is affecting our children. And this is the future of America. These kids are growing up and are going to be even bigger than we are. It is not related to race. It is across the board. So at this point, obesity has become the second most common preventable cause of death. Smoking is the #1 cause. Rates of smoking are going down and rates of obesity are rising. It is estimated that in the very near future, obesity will become the most common cause of death from a modifiable behavioral risk factor. Already, more people die from obesity or the diseases related to obesity than breast cancer and colon cancer combined. And in the very near future, we expect the deaths from obesity to overtake those caused by tobacco. So obesity affects every aspect of your life, from shortening your life to the quality of life to the diseases you develop as a result of the obesity, such as diabetes and hypertension and high cholesterol and sleep apnea. These are related to disability in terms of time off from work, and it all is related to increased cost and care. So what can we do? Well, this is a disease that on average costs people 10 to 15 years of their life. There was a study approximately 10 years ago that came out of Sweden that was published in the New England Journal of Medicine that studied a large number of patients. Sweden has socialized medicine, and they were able to, because of this, follow 100% of patients who had weight loss surgery and compared them to people who were morbidly obese and did not have weight loss surgery. And they've had a lot of interesting findings, but one of the most important findings was that the group of folks who had surgery and lost weight lived 10 to 15 years longer than the patients who were morbidly obese. And as you can see by this graph, as your body mass index goes up, your risk of mortality goes up. And we know that if you're an African American male with morbid obesity, on average, it reduces your life expectancy by 22 years. In Caucasian males, it's by 12 years. Caucasian females, 8 years, and African American females, 4 years. We know that this impairs your quality of life by loss of self-esteem, an exponential increase in the incidence of depression and discrimination, both in society and in the professional world. So what are the options for this disease? Well, diet and exercise, which if you're watching this video, I imagine you have tried multiple times. The fact is that diet and exercise works less than 5% of the time for people in terms of prolonged, sustained weight loss. I hear every day in my office patients saying, well, I've lost the weight, the problem is keeping it off. People yo-yo back and forth. They lose the weight, then gain more back. That is not a durable, sustained weight loss. Behavioral modifications such as hypnosis works. However, much like diet and exercise, behavioral modification does not have a good long-term result when it comes to sustained weight loss. Anti-obesity drugs, there are a lot of popular drugs, anti-obesity drugs, weight loss drugs that have hit the market in the last 5 to 10 years. They all have side effects, and the amount of weight loss that they cause is very suboptimal when compared to surgery. You're talking about, on average, about a 5 to 10% weight loss with these drugs. And when you stop taking them, people tend to gain weight, whether their appetite returns or they lose the malabsorptive component of the drug. But the weight tends to come back. So in 1991, the National Institute of Health convened a conference of experts from around the world in obesity. And from this, we have our consensus statement regarding bariatric surgery. And from this, you can see the quotes. For patients with morbid obesity, surgical intervention is the only method proven to have a significant long-term impact on the disease, which is obesity, and should be considered when medical interventions such as diet and exercise have failed. So why not consider surgery? Well, diet and exercise only work in about 5% or less of people who are morbidly obese. Surgery is safe and effective, and in fact, the mortality rate from both a laparoscopic Roux-en-Y gastric bypass or a sleeve gastrectomy in the United States is less than the mortality rate from a laparoscopic cholecystectomy, which is having your gallbladder removed. We know that weight loss surgery improves your comorbidities. If you were to have a gastric bypass today, for example, and you're a non-insulin dependent diabetic for under 7 years, you have about a 75 to 80% chance of the diabetes going away, meaning normal blood sugars, no diabetic medications, and normal hemoglobin A1Cs. When you lose the weight, we know that some of this life expectancy that was decreased because of the morbid obesity will increase, so it does lengthen your life as well. The benefits of surgery certainly outweigh the risks of staying morbidly obese. In order to qualify for surgery, your body mass index must be 40 or greater or above 35 with significant comorbidities such as high blood pressure, high cholesterol, diabetes, sleep apnea, heart disease, reflux, urinary stress incontinence, joint pain, swelling in your legs, back pain, just to name a few. So what options are out there? Well, there are two types of procedures that you can have done. One is considered restrictive and one is considered malabsorptive. What has evolved from these procedures is a combined restrictive and malabsorptive procedure, meaning a smaller stomach with a shorter digestive tract. What this means, and what we offer here at the University of Florida for primary operations, non-revisional surgeries, are laparoscopic Roux-en-Y gastric bypass and laparoscopic sleeve gastrectomies. These are both restrictive operations and they both have a malabsorptive component to them. The laparoscopic Roux-en-Y gastric bypass has been around the longest of the two procedures. This was born out of old ulcer operations. Old ulcer operations required that we remove portions of the stomach and reconnect the small bowel to the stomach. As a result, surgeons noticed that patients who underwent these operations lost weight and certain health problems like diabetes improved and or went away over time. As a result, this became a standalone procedure. The laparoscopic revolution really changed the way we do this procedure, and in 1993 it was done laparoscopically for the first time. The laparoscopic revolution has made this a much quicker recovery, and on average people stay in the hospital approximately 1 night. It does take 2 to 3 weeks to feel back to yourself, but this operation offers a 70% average excess weight loss. So if you're 100 pounds overweight, on average, people lose about 70%. Nationwide, the mortality risk is about 0.12%, which is slightly better than gallbladder surgery, which carries a mortality rate of 0.2% nationwide. The other option for a primary procedure that we offer is a sleeve gastrectomy. The sleeve gastrectomy is a little bit of a newer procedure. There are about 10 to 15 years of experience behind this. We know that this is a safe and effective operation. The mortality rate for this operation is 0.08% nationwide. This operation has better weight loss than the lap band, which we don't offer here anymore. With fewer complications, however, the weight loss is not as good on average as the gastric bypass. On average, people lose about 50 to 60% of their excess weight with this operation. So if you're 100 pounds overweight, about 50 to 60 pounds. One other thing that is important to understand about this sleeve gastrectomy is that it can cause people to have reflux, or it can potentially make your reflux worse. And it's difficult to predict who that's on, so I warn all of my patients about the possibility of that. We see patients here who've had adjustable gastric bands, and we manage the bands. We also do a lot of conversions where we remove the band and convert the operation to a gastric bypass or to a sleeve gastrectomy. Lap bands have fallen out of favor for the majority of surgeons and patients. They were very frustrating to manage. They were foreign bodies that were meant to stay in your body for the rest of your life, and as a result, the potential complications from this operation were additive over time, and the reoperation rate for the adjustable gastric band was very, very high. There are a lot of misconceptions about surgery and bariatric surgery in particular, and one is that bariatric surgery is dangerous and should only be undertaken as a last resort therapy. Well, bariatric surgery has come a long way in the last 20 or 30 years. It is safe, it is effective, it is the most effective means of weight loss out there when diet and exercise have failed. In terms of the risk of surgery, there are multiple studies looking at this. And we now have a nationwide database that we can draw out of and determine what the mortality and complication risks are nationwide. But prior to this database, several studies were done looking at this, and the overall mortality risk was less than 0.2%, which is in line with our national database. We know that the benefits of surgery aren't just about the weight loss, but it can help cure diabetes, sleep apnea, high blood pressure, high cholesterol, and many other problems. It can also extend your life on average by 10 to 15 years. And these are some of the results of losing the weight and having on the comorbidities related to obesity. The incidence of migraines goes down 60%. 60% of folks who have migraines and have weight loss surgery and lose the weight, their migraines go away. Hypercholesterolemia, high cholesterol, about 2/3 of patients who have surgery and lose the weight, the high cholesterol goes away. Fatty liver disease is a hot topic right now, and our colleagues in liver transplantation believe that fatty liver disease is going to overtake all the other reasons like hepatitis and alcohol as the #1 reason for cirrhosis and liver failure in the near future. Fortunately, the majority of the time, fatty liver disease is reversible when you lose the weight. Type 2 diabetes or non-insulin dependent diabetes goes away up to 80% of the time when you have had the diabetes for under 7 years. We see people with sleep apnea all the time, and approximately 95% of our patients who lose the weight end up getting off their CPAP machine. There's a lot of data about high blood pressure getting better and going away, and somewhere around 70% of the time our patients get off their hypertensive medications. We've talked about reflux in the prior slides. A gastric bypass typically gets rid of reflux. A sleeve gastrectomy can make reflux worse, and that is impossible to predict preoperatively. We know that morbid obesity increases the risk of cancers: esophageal cancer, stomach cancer, breast cancer, colon cancer, pancreas cancer, uterine cancer, ovarian cancer, just to name a few. When you lose the weight, the risk of these cancers go down as well. So other benefits of surgery, certainly we are in favor of this, trying to get you off as many of the medications as we safely can. Another misconception that we fight is that the results don't last. We know through several studies that results do last. Now, there are things the patient can do to help that, and certainly going through an accredited program such as ours will help with your not only avoiding complications, but improve your results. Patients who stay in an accredited program after surgery and are compliant with the recommended follow-up tend to maintain their weight loss better than people who are lost to follow-up as well. But we know that looking in the long term, there is plenty of data suggesting that people maintain their weight loss years and years out from surgery. So here at the University of Florida, we are a multidisciplinary team, and we are an accredited center by the MBS AQUIP program through the ASMBS. This is our team. You've met the doctors. You will see through our program one of our psychologists, led by Allison Holgerson. You may see Tammy Lux, who's our physician assistant, Alba Osorio, who is our dedicated bariatric dietitian, Gwen Haas, who is our nurse coordinator, Stephanie Stevens and Tisha Redondo are both our surgical coordinators who will help guide you through this process in clinic. And Tina Adams is our insurance specialist who is fighting these insurance companies to get your operation approved. Again, to have surgery, you must have a body mass index of 40 or over, or have a body mass index of 35 or higher with significant medical problems related to your obesity, such as high blood pressure, high cholesterol, sleep apnea, diabetes, or reflux, to name a few. Some insurance providers require documentation of weight history from your primary care doctor, or will require what's called a physician-supervised weight loss trial. Every insurance is a little different, and you may want to contact your insurance company through the 1-800 number on the back of your insurance card to see, number one, if you have bariatric benefits, and number two, if you have a physician-supervised weight loss trial that is required prior to surgery. Our patients must be both nicotine-free and drug-free for 3 months or greater. Smoking increases the risks of complications following these surgeries. The process will become, once you call and get an appointment, you will come and see one of us in clinic. We will meet you, take a history and a physical, and review your surgical options. Once you leave our clinic, if you decide to proceed, you can expect to receive a checklist where you will be required to get a lot of blood work, a swallow study or an upper GI, or possibly even an upper endoscopy. You may need a sleep study. If your colonoscopy is not up to date, you will need a colonoscopy. And you will need to see our nutritionist, Alba Osorio, and our psychologist for an evaluation and a bariatric clearance. Here at University of Florida, we're also on the cutting edge of research, and we have several affiliations with other divisions and have a NIH-funded research project that if you choose to have surgery with us, you may qualify for. Our NIH-funded study is through the Cognitive Aging and Memory Center, and it's looking at the way obesity affects your memory and how losing the weight and the resolution of some of the comorbidities may improve the memory. It will require that you have 3 MRIs of your brain, both before and after surgery, and undergo some testing. And if you qualify for this study and decide to participate, there is some financial gain for you in it. This question gets asked to me every day, Doc, what procedure is best for me? Well, I don't know. You and I are just meeting. And I think it's very important that you pick the operation that you think is best for you. I will answer your questions all day long, but I don't make your mind up. I think it's very important that you decide which operation you want. Regardless, you need to be ready and you need to be committed to this. This requires a lifelong change in habits and in your life. You need to be committed to the recommended diet following surgery. the recommended nutritional supplements, the vitamins, the calcium, the vitamin B12. You need to be committed to some sort of exercise, and you need to be committed to the recommended follow-up with us. We know that the patients who follow up with their surgeon and stay in their program maintain their weight loss in the long run. We're very proud of our multidisciplinary approach. We do have and are certified through the MBS AQUIP program, which is a combined program through the American Society of Metabolic and Bariatric Surgery and the American College of Surgeons, which assures that we are doing the highest level and quality of care and providing the highest level and quality of care. We have consistent and optimal results. We do offer a monthly support group that is the second Tuesday of every month at 6 p.m. that is open to both patients pre-op and post-op. So thank you for joining us. Hope you learned something. We look forward to seeing you in our clinic.